Well, today I am very honored to have a heavyweight. I mean, if there were heavyweights of biomechanics, I would put Dr. Chockalingam in the sort of Muhammad Ali, Mike Tyson category because he kind of covers both ends of it. He has not only the academic piece, but he's also, without commercial interest, very penetrated into being consulting for companies and, again, independently, which I think is a great thing for science. He is a professor at the University of Strattonshire.
Staffordshire.
Okay. And without further ado, give me sort of a sense. We're at a very interesting time, I think, in biomechanics with allied health, podiatry, retail. You've done some interesting work that I heard on one of your other podcasts, Boom, that they did an interview where you kind of looked at stratifications of the cost effectiveness of some of the interventions we use, such as orthotics. I don't know how far you are in that, so I thought this would be a great opportunity maybe to lead off with that and give us some perspective.
Sure. Thanks for Ben, and I'm really honored to be on this kind of podcast. As you said, I lead a team of engineers and scientists here at the Center for Biomechanics and Rehabilitation Technologies at Staffordshire University. For people who are listening who don't know where Stoke-on-Trent or Staffordshire is, it's in the middle of England. It's between Manchester and Stoke-on-Trent, Manchester and Birmingham, in a place called Stoke-on-Trent, which is known for its potteries. People know Wedgwood and the potteries, and that comes from Stoke-on-Trent. That's where I live, and that's where I work. We've got a fantastic facility downstairs to do all sorts of measurements in human form and function. So I lead a team of engineers and scientists who we are interested in measuring all aspects of human form and function. So your question was relating to, in terms of cost effectiveness and the clinical effectiveness of orthotics. This is something which is of interest, and we started doing some work with ISPO, International Society of Prosthetics and Orthotics, on the WHO, the World Health Organization, in terms of developing guidelines for setting up P&O services. So as a part of that, we looked at the system. We looked at the literature, scientific literature, systematically to understand what is available in terms of clinical effectiveness of orthotics and prosthetics, and also the cost effectiveness.
A meta-analysis, if you will, that type of breakout.
Yeah,
Did you do a meta-analysis?
We did, and it's already been published. The systematic review is published. Some aspects of meta-analysis is also published in various forums. So people can look out and ask Google for all the answers in terms of our work. Just to give you a highlight, in terms of orthotics itself, and when I talk about orthotics, I talk loosely in terms of orthotics rather than just foot orthotics. So I talk about knee braces, spinal bracing, neck bracing, whatever type of orthotic people think about. There are certain devices which have been shown to be cost effective. Many of these devices have shown to be clinically effective, but only few have shown to be cost effective. But if you ask me as a scientist, do I believe in some of these commercial stuff and whether it is expensive, whether it is cost effective? I don't think I'm in a position to answer that at the moment. Mainly because there's not been structured research to showcase the clinical effectiveness, the cost effectiveness of some of these devices. The reason being, some of these devices are so clinically focused and it's given to a group of individuals who need it. Sometimes it might not be easier to look at a large series of patients with a specific type of device, because these devices are designed for individuals to deal with an individual condition. So sometimes to take to the next step to understand the clinical effectiveness and cost effectiveness would be difficult unless we do a large scale randomized controlled trials. And that's what is lacking. There are certain things that we could do in terms of, say, foot orthotics, foot at risk, some of the devices that we have given to support the foot in terms of mechanical function. It's shown to be cost effective, and there's been some studies on it which we have quoted in our own paper and in our analysis.
I think you bring up a great point, or several points out of that soundbite. It was a big one, because what's interesting about what you just said is that even amongst, quote, foot orthotics, what is a foot orthotic? We have, so you might have a study that they used an orthotic device. It might be one particular time, but then, I've had the opportunity to talk to people like Richard Blake. He has these high inversion orthotics to try to create a moment. And his thought process is it takes many degrees of quote unquote correction to have even a small degree of impact on the translational motion. So that's just one example. There's so many. And then the other thing that I appreciate is that, depending on which body part, you might do fine with something more neutral, as in less customization on one body part. And I'm not even going to pick an example because, for instance, I don't know enough about the back other than its relationship to gait and things that I've started paying attention to be able to, postulate, whether, a back brace with some type of correctional in the translational of 3 planes for scoliosis would be, something that didn't require as much customization as any other type of body part. But you bring a lot of food for thought. So here's, I guess, another question, and this, I'm going to go kind of in the opposite direction. What about measurements? We now have so many commercial opportunities as smaller clinics to so-called build up a gait lab. And I want to say this with an asterisk, not necessarily a gait lab that an insurance company will recognize, because that is very specific, as I've just learned from talking to Paul Kesselman here in the US. He's very dialed in with the requirements that insurance companies require. 3 different orientations with cameras, dedicated, not in your hallway of your clinic, dedicated. So not to say that we couldn't do some specific analysis for a sport, but it would have to be part of an extended consultation versus a quote gait evaluation, like maybe the ones that you do at the university. But give me kind of a sense, and I know you probably want to be a little careful about, bashing one commercial company, but maybe kind of the types of things so that they could key in and say, this pressure sensor is a little thick. It might be giving incorrect measurements within a shoe because of its girth, et cetera, on things to look for, so that they can kind of weed out and say, is this something I want to implement in my clinic?
Yeah, it's a brilliant conversation to have, isn't it, Brent? I think you're picking this up from the previous conversation we had during my talk, the earlier talk. I think I'll take a step back. And one of the things for me this year as a theme is about bringing science to frontline clinics. As scientists, we could do all sorts of things in the lab. We have all singing, all dancing equipment to measure anything we like, but it is about bringing that, and we can go and publish those as scientific manuscripts or clinical manuscripts. It's about translating the information that we produce in the lab to frontline clinic, which would benefit both the clinician, the practitioner, and also the patient. At the end of the day, you and I are sitting here to make sure that the patient who's walking into that clinic gets better soon. So it's about making use of that data. So it is about translating that scientific data to the benefit of the practitioner and the patient. So talking about data itself, So you touched on gait analysis and you touched on all of the equipment. Say, when I started my gait analysis, I still remember I was one of those first few people who used the old camera-based motion capture systems where we have to sit in and then digitize for hours using a mouse keypad and a big projector. But now we have got tiny devices, IMU devices, that we could put it on someone's body segment, and then we can measure in 3 dimensions and continuously for a certain number of period. So it is about the technology is advanced. It's that difference between technology and the technique. Sometimes you could use simpler technologies with appropriate technique to achieve the same data, which would be beneficial both for the practitioner and the patient. So that's what that people need to understand the difference between the technology and the technique. A lot of the times, frontline clinicians are being sold by some of these, what's the word I'm looking for here? Some of the commercial vendors and their sales pitch, and people get carried away by saying, I need that system, which is going to cost me so many thousands of dollars. You might not need it. You might need a simpler couple of dollar device, which would give you the data that you want. It is about that balance between the technology and the technique. So you have really expensive technologies, which can do all sorts of data capture analysis. You also have simpler techniques, which can be adapted to give you the right amount of data for an effective clinical management. That's that balance.
I want to follow up on that because it's you bring up a great point on utility for the type of problem you're trying to solve. So I briefly had a contracted a pet orthotist, and he was great. He in fact ran a meeting, and I was invited once, and at any rate, he would use something as simple as, I call it the gentian violet, but it was like purple ink, and it was a little thing like a little squeegee. And then he'd have the patient sit down and just looking at pressure points, submet 5, submet 1, submet 2, those are generally the big hot spots. Now, what I understand the benefit of the time-related pressure measurements is that now you're getting that 3-dimensional sequence, not just in terms of more 3-dimensional, but literally adding the dimension of time into the 4th dimension. Sure. What would be a clinical scenario where you would say, you know what, it might be worth it in this particular point? It could be the swing of a baseball player in their stance at home plate to a midfoot Charcot breakdown where you're not as clear about the contact points because it's kind of an inverted boat kind of a thing. What might be one example where you might say, I think this needs something a little more evolved to answer the clinical question?
Okay. I'm just trying to think.
And I hope it's not too specific of a question, but why would we want to go to a more sophisticated measurement system? Yeah. What would be an example where it's not cutting it just to say, look, you're going to do the same thing. You see the fifth med is plantar flexed, the foot's in a verum position, and you just got to do an offload the fifth med. Why do you need a $7,000 unit? Sure. And that's a very simplistic type of approach. However, there might be some more nuanced clinical questions to answer.
Absolutely, and one of the things is people normally ask me, "Oh, we gait analysis. The first thing to do in gait analysis is see someone walk. My eyes is my best judge, and I can see my patient walk, and I can judge whether they've improved or not improved." Yes, you could, but the main thing is about using the technology to do repeatable measurements. So your patient walks in, you do some clinical assessment, you make notes, but can you communicate that notes which is in your brain because it's in your eyes? You know what that patient looks like and you know what that patient has. It's about you communicating it to your colleague who might end up seeing the same patient in a few weeks' time because you might be on a holiday. If that's the case, it is about objectivizing the data. So if you could support your clinical decision based on the data, then it becomes easier. That's where you need technology. So when I talk about technology in terms of gait analysis, it's not about complicated optoelectronic systems or complicated camera-based systems. It is about you could use a pressure walkway. It is about the type of patient. It is about what outcome measures you want to use. As long as you have data which can support your clinical decision, and many times it is about that technology that you use. If you use appropriate technology, and if you could make appropriate measurements, and this is where we talked about last time, it is when we use the technology, it's appropriate use of technology too. And we'll come back to that in a minute. I guess when we talk about pressure measurement, and one of the common things that I see all the time when I travel around the world is the calibration of pressure system and the use of pressure systems from various vendors and various technologies. So it is about using appropriate technology which would support good quality data, repeatable data, reliable data, which can be stored so that you could see the care pathway for that particular patient. And also it helps you communicate it to your colleagues and to the patient. Does that make sense?
Yes, makes great sense. And several ideas come to mind. One, and I don't know if it's a company that you might have been familiar with, but and this might have been in I want to say the mid 90s. There was a Canadian company called Footmax, and they tried their own version of a pressure mat. Only problem was it was a small mat, and you literally had to game your gait to step on the appropriate point. And as you know, and some of the viewers might not know, the more sophisticated gait labs, it's a random thing. It's under, and it's like it's on a mat, a flat runway, and you don't even know where the mat is, which is perfect because you can't just like, okay, let me get to that step and place down. So not only did, in my opinion, and I think a lot of people's opinion, that system proved to be unreliable for repeatable measurements, to your point, but what you were getting spewed out, and I think this is the other end of this, the funnel, was not a customized algorithmic type device. Rather, you were getting the number 7, and then it would be shipped out to you, and it would be a fairly low contour type device, which meant that there was less liability for the company to have a send back, because maybe it's not going for the triple or the home run, but they were happy just to get a single, in terms of the impact it was going to have on the patient. So I think that is a perfect example of something where you have a so-called dressed up piece of technology that really isn't doing a whole lot.
Sure.
I'd like to take for a minute, and this might be a little bit of a hot potato, but I've always had a little bit of trouble with something that might be partly effective, but a little bit not even shooting for the fences, but really just trying to, I guess, get the base hit. Would you offer me an opinion? And I don't know how big chiropractic is in the UK. It's very big here in the US. Sure. And I think there are some brilliant chiropractors who put together the relationship of the back and some of the active stretch release things that they've helped to move that science forward. But insofar as something like the foot levelers, yeah, you're getting a little bit of something, but it's hardly more than a Dr. Scholl's in terms of the contours. Any thought process about that? And then getting back to your cost effectiveness scenario. I'm sure that they're probably not even maybe somewhere in the neighborhood of half to 1/3 the price that a podiatrist here in the US might charge for some custom orthotics that we would make.
Sure.
So, you know, throwing you a hot potato to see how you what your thought process would be, and you know, you can just kind of give me what your general thoughts would be.
Sure. The thing is, it's difficult because I'm not a clinician and I won't pretend to be one. I'm a scientist and I'm interested in measuring stuff rather than providing clinical management of solutions. Having said that, having worked with podiatrists, chiropractors, orthopedic surgeons, physios, a whole variety of clinicians and clinical practitioners, I can tell you this. Each and every clinical profession has its own advantages. They have specific ways of treating the patient. But at the end of the day, all of them have the same goal of getting the patient better. And one of the things that one of my previous papers, I think you might have seen it in my previous lecture, is to showcase the differences in clinical training and clinical approaches. We did this piece of work where we invited top 5 orthotists in the country and top 5 podiatrists in the country. We presented them with one patient. And then the only thing that we told them is, in case if you need to prescribe an orthotic, you need to use a foam box. Plaster Paris cast rather than a foam box. And then all these, and this is a kind of semi-professional athlete who complained of anterior knee pain. And then we gave her a clear script of how she describes a clinical condition to these people. So they went in, took history, all of them decided that they need to give her an orthotic. Then if you see in our paper, which is published in Gait and Posture, and published in Clinical Biomechanics, I think, and Ben, you could provide the link to the paper as part of the blog, if you like. And if you see, we've got totally 10 different devices. And all of them, their main outcome was to achieve symmetry between left and right and to reduce the pain for this patient. But if you see, there are the devices, physically, they look totally different. So that, and out of which, then we followed up with the patient, we gave them, but then it becomes very difficult for a scientist to give which device would work for this patient. We don't know. And if you see all of these research papers published, they'll use one clinician, and many of those papers won't really describe what materials they have used, what type of training this clinician had, and how they approach the problem. Without that, we take, for this device works for this clinical condition. But there is a lot of unknowns before that point. So that's something that we as clinical community and scientific community needs to deal with. That's something that I've been championing for quite some time now. But to go back to your question in terms of clinical effectiveness and cost effectiveness, in terms of cost effectiveness, there are a lot of things which has changed in the recent past. Technology has come down in cost. And in terms of manufacturing, we have 3D printing facility, additive manufacturing facilities have come in, which has reduced the cost. So in terms of cost effectiveness, I think in any type of orthotic device, we can provide cost-effective intervention. I don't think, even for a minute, I wouldn't think it's not possible. Definitely, it is possible in terms of cost effectiveness. In terms of clinical effectiveness, it's a totally different cup of tea. And if you go back to what I just said, in terms of these 10 clinicians with one patient, 10 different devices, then it becomes difficult. Which one of these clinicians is right? Which one of these devices is right?
I love it. So one more thing came out of that for me that you'll appreciate. And we're going to get back to the kind of connection of the different body parts with this. So I interviewed Ben Onig, PhD out of Calgary, and he gave a personal anecdote of a situation where he had some corrective knee surgery. And I can't remember if he was in valgum or verum, but they took him to, looking at it, a perfect X-ray result. And he actually had a knee replacement. Okay. And so, obviously they can carve the bone to specs and translate, directionally, frontal plane, et cetera, different directions. So although it looked good from a standpoint of alignment with his knee, he then picked up an ankle problem right after the surgery. So unintended consequences, and I think that highlights the sort of inter-patient variability because we're all put together so different. So that is yet another area to examine. I love the fact that you brought different clinicians together and opened that whole thing in terms of not only how we are evaluating, but what specialty is evaluating and what their focal point is. Now tell me a little bit about maybe something that we wouldn't realize that we could take to the clinic. And I know that you like to keep it germane to the data, but we see patients in our offices with lumbar twists, whether it be triplanar scoliosis or simple drop of one side of the lumbar. I know that Richard Blake has filled me in with a very good evaluation of don't just look at the shoulder drop because it could be that, we all know you can be right-handed, right-hand dominant. But not only that, but the musculature will develop the striations at a different pitch when you look at a patient dead on. So you do have to look at where the fingers lie when you're standing up as well to correlate what you think you're seeing with, let's say, a right shoulder drop. And then, of course, taking a look at the hip. What would be something that you would say that you've picked up on that a lot of clinicians might not realize about maybe a connection between the back, could be the hips, to the foot? If you have a couple examples of any clinical specific questions that you were asked to answer with some of your papers.
So one of the things, my main area of work with back is relating to adolescent idiopathic scoliosis. So I've done work on scoliosis for a very long time, and we still continue to do and understand why these children develop scoliosis. And I'm interested in the pathomechanics and the etiology of scoliosis. To answer your question in terms of the relationship between back and the lower limbs, there's been some of my students have done some work. One of the work that people can read about is Nev Parker, who did a piece of work with half-length, full-length foot orthotics and how it changes the pelvic posture. And then there's another piece of work done by Jennifer in terms of understanding pregnant women and low back pain and how footwear and orthotics and footwear choice does influence it. Some of this work is available online. So definitely there is a link. Have we quantified it enough to inform clinical practice? I would say we're not there yet. That's mainly because of understanding the low back and pelvic kinematics. At the moment, what we have got is surface markers-based system that we use to understand the pelvic kinematics or the low back kinematics during walking or doing any physical activity. We fully don't understand what happens inside the joints, in the articulating surfaces inside the joints, which makes that subtle differences. Those subtle differences makes that bigger change in terms of pain and pain management. So we still need to develop, that's what Jennifer's work was to develop protocols to understand some of these subtle movements during activities of daily living, which would then help us manage low back pain. One of the things clinicians, either podiatrists, physios, orthopedic surgeons, talk about is limb length inequality, and then whether which one is clinically significant. Is it 1 centimeter clinically significant, 2 centimeters? When would you start intervening? All that. So it again depends on the type of patient you see and the clinical assessment and the symptomology of these patients. One of the other things that we are doing now with my colleagues in Serbia, and what we are trying to understand, is the influence of pelvic posture, the back posture, and the back surface topography on these patients. And one of the things, Ben, I've come to understand in the last 3-4 years is not just about orthotics. It's not just about general physiotherapy. It is about focus, strength, and conditioning. So if we can have focus, strength, and conditioning intervention, many of these musculoskeletal issues relating to the back and the lower limb can be managed effectively. And that's an area that still there is a lot of scientific work needs to be done. Structured scientific work needs to be done in terms of understanding how we could introduce strength and conditioning.
I'm glad you brought that up. As I've interviewed top field experts like yourself, I've stumbled into other pockets where, let's say, I'll be listening to a strength and conditioning coach at one of these NFL combines and just give some brilliant, subtle things about the torque moments that occur. And I feel like as clinicians, we need to be doing more than, as Simon Bartold states, looking at the frontal plane fit to vertical model of something very static, and looking at the whole picture.
Absolutely.
As you know, Ben Onig did a lot of research in terms of looking at the torques being more important, in his opinion, than what we're seeing visually.
Sure.
And that is another area that's obviously harder for a clinician that doesn't have those more sophisticated tools to assess. So that's why we're relying on people like yourself to help us sort through. So I'll be looking forward to some of those conclusions. But again, a lot of stratification, but at least we are pointing into trends, and I think asking better questions.